Share screen with you guys. Let's try again, it says. Is anyone here? Hello? Let's refresh. Okay, now I think it's working. Alright, can you guys see my screen?
No.
Right. This thing has been a disaster since they updated it. Okay, I'm going to log out and come back in. I don't know what's wrong with it. I'll be right back. Okay. It will not let me share my screen, so let's see if it will let me pull in the lectures. If not, then we have an actual problem. That's showing the screen. That's recording. Let's see here. We are in week 9. We are doing chapters 16 through 18. Empty slides. Module 4. 16, 17, 18. See if it downloads both. All of those. It does. Very good. Okay. It says that it downloaded both of those. Go here. Manage presentation. Here. Downloads. Let's do this one. This one. Just trying to make it work. Stand by. For whatever reason, it will not screen share. Okay. It actually worked. Let's see if it will let me switch to 16. Okay. Beautiful. I think that it has worked. Um, Unfortunately, I can't let you see the roster as I call roll, but I'm going to give it a shot anyways, and I'll call it without you being able to see it. And let me know if I'm not seeing anyone in the chat because, again, once I switch over, I can't see both. So let's call roll. Ariane Palmer, are you here? Ariane?
Ariane Bramar here.
Cameron Pierce? Cameron Lanford?
Cameron Lanford.
Charlotte McMahon?
Charlotte McMahon.
Krista Joby? Sierra Mitchell?
Sierra's here.
Claire Kimichek?
Claire Kamichik.
Cynthia Earhart?
Cynthia's here.
Dylan Bell?
Dylan Bell.
Emily Burke? Faith Pinkney?
Faith Pinkney.
Jen Hernandez? Bang Juckett? Bang Juckett. Okay. Kelsey Hearing?
Kelsey Hearing.
Leslie Williamson? Maddie Dole?
Here.
Maria Barufi is here. Mazara Rocha?
Maestra Rocha.
Mitchell Hinton?
Mitchell.
Nicole Tenorello? Noah Wilson?
Bo Tenorello.
Ryan Jackson?
Ryan Jackson.
Sarah Coker?
Sarah Coker.
Is Noah Wilson here? Sierra Altman?
I'm pretty sure Noah's sick.
Okay. Sierra Altman? Stephanie Wilcox? Tony Warnick? Okay. Tony Warnick? Vishnu Goodavada? And Wilson?
Here, Vishnu Goodavada.
Okay. Wilson Maddox?
Wilson Maddox.
Is Tony here?
Tony's here and Leslie Williamson is here.
Okay, Tony and Leslie. Okay, the only people I have absent are Altman, Noah Wilson, Emily Burke, Krista Joby, and Cameron Pierce. I show you absent. Okay, no worries. Let's jump right in. Obviously, we're done with the assessment module. So we will begin rides. This week I will post the schedule for your availability. I remind you that if I do not have a signed, submitted shot verification form, I cannot put you on ride-alongs. If you've not taken the assessment module because you were sick or otherwise, you cannot begin ride-alongs. If you do not make that up by Thursday, you cannot proceed with the class. Keep that in mind. I will reach out to those people individually who apply to that as far as making up the assessment module. Those of you who have not gotten shot verification forms done, let's make sure we get those done this weekend, this week or next. That needs to happen quickly. I will again review the clinical ride-along information so that we have a review of the requirements and the expectations, and then you guys will begin getting on ambulances, which is exciting. So remember to go out and get your little uniform pants if you need uniform pants and shoes and belts, whatever you need. Make sure you're getting that. Remember not to spend a ton of money. It doesn't have to look incredible. It just needs to look per the standard we set in the lab last week when we reviewed all of this. Okay, if you have questions about that, you know to reach out to me and I can answer them for you as to what is acceptable and what is not. We'll review that again this week in lab. I will be with you again for both days of lab. Let me double check that to be sure I'm not crazy. Yes, I'll be with you again for both days of lab. So we will have that together. This week, we begin the chapter material. We've already looked at pharmacology, and that was an oopsie on the assessment module that I wasn't aware of, and so she put that on there, and no one knew it. So that kind of benefited some of you, and I'm glad that it did. That works out for me and for you, because I don't want to see any of you go away. But please remember to keep studying that material remember that it will show up again, that you will see more pharmacology in the medical module. So keep studying the assessment stuff, keep studying the pharmacology stuff. Today we begin the individual components. Remember that in the medical patient, we're talking about the systems. What are the common emergencies that the EMT will be expected to treat and manage based on the systems? When we think about the systems, as we remember from the assessment portion of our secondary head to toe, you're thinking about neuro, head, ears, eyes, nose, and throat, also known as HEENT. We're thinking about pulmonary. We're thinking about cardiovascular. We're thinking about the abdominal quadrants and what goes wrong with the abdomen. We're thinking about the endocrine system, such as our diabetic patients. We're thinking about the blood system, such as our sickle cell patients, such as our hemodialysis patients. We're thinking about the skin patients that we see for environmental exposures, cold and hot, and anaphylaxis, and exposures to biting and stinging insects. So when you think about the medical module, think about the systems. What are the most common emergencies that go wrong with those systems, and what are the capabilities of the EMT in responding to those system-based emergencies? I bring you back to the assessment talk of who are you assessing, a medical patient or a trauma patient? In the medical patient, our head to toe should be about assessing the normal or the abnormal findings of the systems. Are you familiar with them from head to toe? Do you know how the medical patient differs from the trauma patient exam? In the trauma patient exam, we're talking more external. We're talking more hands-on. I'm going to feel it and palpate it. I'm looking at decap BTLS, deformities, contusions and crepitus, abrasions, punctures, penetrations, burns, tenderness, laceration, and swelling. That would be the center focus of the trauma exam. It's not so in the medical. I remind you that you shouldn't be decap BTLSing the medical patient unless you can articulate that they are both a medical patient and a trauma patient, which I remind you won't occur in the classroom environment. It will occur in the real world, but it won't be in the classroom environment. We will not try to make your exam questions, your psychomotor exams, we will not try to make them that complex. Give me 2 seconds to answer this. I apologize, guys. All right. So again, making sure that you understand those differences, making sure you understand which patient you're assessing. So let's focus on medical. Let's focus on the systems. And we're going to begin with respiratory, then cardio, and then with neuro. And I remind you that my job is not to read the book to you. My job is not to make you study in some way that'll pass the test. You have to do that work on your own. You have to read the chapter, whether you like it or not, even if that means you listen to it audibly. I don't care what you have to do, but you have to read the chapters because I can't give you all of that information. I have to give you the meat and potatoes that are, one, most important for you to take care of the patient, the real patients that actually will exist, and two, the information I know you will see to the best of my ability in the coming exams. So that's what I will be doing with each chapter. You need to go through the slides slowly. You need to read the chapter material as best you can. Okay? So let's get started with respiratory. My main point to you from the perspective of each one of these chapters is going to be, what are the most common emergencies of that system? And what are the ingredients of that emergency? If you were looking at this patient's primary exam, their secondary exam, their sample, their OPQRST, what would be the ingredients that would equal XYZ emergency? That's what I'm going to do for you. In every single one of the medical chapters, it is going to again reiterate to you that you must know the anatomy and physiology of that particular system. If you don't know how something exists in its anatomics and how it functions in those anatomics, it's going to be very difficult for you to then know how it breaks. If you don't understand how it breaks, then you can't fix it. So this is all about the study portion so that you can receive the emergency, find it to be your field impression, and then do the appropriate things about it. We will begin with epiglottitis. So for each one of these, I want you to write down the ingredients that I give you for each one of these emergencies. Okay? Epiglottitis will be our first one. Epiglottitis is most common in children. It can occur in adults, but that is very rare. So when you think of epiglottitis, you should think pediatric emergency. Epiglottitis is exactly what it says. The inflammation of the epiglottis secondary to bacterial infection, most commonly. There is a key presentation to epiglottitis that you should know, and if you see it on a test question, it should be a trigger word to you, and that trigger word is drooling. If you were to see a test question that said you have a 24-month-old kid, fevers intermittently, respiratory distress during the day that gets really bad at night, the patient is having so much trouble breathing that they're sitting forward and drooling, they don't want to swallow, they can't talk to you because their throat hurts so bad, and they're belly breathing, they're working really hard to breathe, that is epiglottitis all day. Bacterial infection of the epiglottis causes it to swell up, so then swallowing is really painful, and drooling occurs because they won't swallow. So the classic example of epiglottitis is a 4-year-old sitting in the tripod position, drooling, who complains of gradual onset, getting worse in time over the last couple of days. It's kind of bad during the day, but it gets really bad at night. Potentially coughing. They might present with a stridor. So then I ask the class again, what is a stridor?
Upper respiratory issue, obstruction.
Yeah, if I hear a stridor, then I know that I have occlusion of the upper airway. So we're talking about squeezing on the nasopharynx, the oropharynx, the hypopharynx. The areas before the glottic opening are swelling up and they're inflamed, they're aggravated, they're irritated, and so therefore there is this stridor that accompanies the attempt to inhale. That should, one, be very worrisome to you, and two, always be indicative that there's a pretty significant emergency here. It doesn't mean get crazy and get all, scared and wigged out, but it does mean, hey, this is serious. I need to take this seriously no matter how good this kid looks, and we need to recommend transport and emergently treat the patient as best we can and transport to the hospital. So drooling is a trigger word. Stridor would be common. Intermittent fevers caused by bacterial infection of the epiglottis. Let me know when you guys have all that down. All right. Spontaneous pneumothorax. Spontaneous pneumothorax is pretty rare. Spontaneous means that it is acute. So if you were looking at onset, you'd be thinking of a patient who was fine, and then all of a sudden they were not. Pneumothorax means that the lung has collapsed and it can't reinflate, which would cause some pretty significant trouble breathing, and if not corrected, could even possibly result in death. Not very common, but it can happen. The case that comes to mind is very recent with an elderly female who was having some intermittent medical conditions, and she was doing pretty well. And she went to the doctor's office, and she was in the waiting room, and then suddenly started having trouble breathing, and by the time we got to the patient, she was in cardiac arrest. Now, that's very rare. That's not very common. Spontaneous means that it wasn't traumatic. It wasn't caused by any mechanism of injury. Normally, when the lung collapses, you think of someone being shot in the chest. You think of someone being stabbed in the chest. You think of someone who might have fallen from a great height and struck their chest when they landed. And so then the lung is punctured by the ribs, or punctured by a bullet, or punctured by a knife, and that causes it to collapse. That causes air to build up in the chest, working against the reinflation of the lung, and so then the patient dies. So the classic symptoms of spontaneous pneumothorax should be acute onset. They were fine, now they're not. Severe trouble breathing. I can't catch my breath. It hurts to breathe. That's called painful dyspnea, right? They're having pain with trouble breathing. Trouble breathing is its own animal, but when you have pain while you breathe, that's a special thing. Okay? Unilateral lung sounds. We are taught that lung sounds are supposed to be clear and equal bilaterally. If I listen with my stethoscope over the left lung and I hear this great air moving in, air moving out, and then I listen over the right lung and nothing. It's dead. Nothing's happening over there. I don't hear any noise. Or maybe I hear faint echoing. That wouldn't be normal. So, classic pneumothorax sign is unilateral lung sounds. You're supposed to have bilateral lung sounds. You're not supposed to have absent sounds on one side. If the right side of the lungs are absent in sounds and the patient was fine and now they're not, 5 minutes ago they were breathing just fine, now suddenly they have trouble breathing and they have great sounds on the left but no sounds on the right, that would concern me for spontaneous pneumothorax. The most common victim of spontaneous pneumothorax, statistically speaking, is tall, fair-skinned white men. There are some theories as to why that is the case, but the general understanding is that the taller you get, the more you are pulling the lung fields down vertically, and so then they can become more susceptible to acute deflation, which would obviously cause some trouble breathing. You're supposed to have two working lungs, and if one of them isn't inflating, that quickly becomes a breathing trouble problem. So spontaneous pneumothorax is the sudden collapsing of one lung or another. You would expect acute onset. You would expect painful dyspnea, trouble breathing that is also painful. You would expect the patient to have unilateral lung sounds. And if uncorrected, some pneumothoraces are so small and they do not progress that they can be watched and monitored by physicians and they never require any acute intervention. But a lot of them, spontaneous pneumothoraces that are greater than 10%, and don't write that down, those will need a chest tube. Those will need intervention. So the way you fix a collapsing lung is by taking the pressure from the chest off that lung. And the way you do that is by poking a hole into the side of the patient's fourth and fifth intercostal space and shoving a tube up and into the lung space and sucking the air that was now released into the chest cavity out and making the lung reinflate. Are there any questions about that? Okay. Everyone's hearing me okay?
Yes.
Okay, beautiful. I got a little worried, got a little nervous. Let's move on to pulmonary edema. Pulmonary edema is classically presented in our patients secondary to a weak heart. The heart's job is to pump the blood, and if it were to be too weak to pump that blood, then some blood would back up from where it came from. So if the right ventricle were to fail, where do you think the fluid would back up? Remember that it backs up from where the fluid came from. So if the right ventricle were to fail, where would the fluid back up? Maria Brufi.
Wouldn't it come out your mouth?
No, no. That is not how that would work. No. Where does the fluid come from that enters the right side of the heart? Where does the blood come from that enters the right side of the heart? The vena cava, yes. And where did the vena cava get that blood? Very good. Where did all that blood come from? That was in the vena cava, and then the vena cava dumped it into the right side of the heart. Where did all that blood come from? It came from the extremities. No, it certainly did not come from the lungs. The left side of the heart is what receives blood from the lungs. The right side of the heart receives blood from the body. So, if a ventricle failing backs the fluid up where it came from, I would expect to see swelling in the periphery. If you look at someone's legs, ankles, shin bones, knees, and they're very swollen, I'd worry about the right ventricle being too weak to do its job. Where will the fluid back up if the left ventricle was too weak to do its job? If you're having trouble answering these questions, then you aren't quite on par with your anatomy and physiology of blood flow. I'd go back and I'd look at that. The left side of the heart, remember this is the patient's left, that blood comes from the lungs. So then if the left ventricle was too weak, it would back fluid up into the lungs. We call that fluid pulmonary edema. And that is, Faith, what causes frothy sputum. Pink, frothy sputum. When fluid cannot be pumped out of the ventricles appropriately, it will back up into the space that it came from. The right side of the heart receives its blood from the body. So then the fluid would back up in the body, as in the legs, the arms, the ankles, the knees, the shins. They would start to swell. The left side of the heart receives its blood from the lungs. If the left ventricle were to fail, it would back fluid up into the lungs, and that is very bad. The causes of this are heart attack, chronic high blood pressure, and other types of diseases of the heart and vasculature, like arteriosclerosis, smoking, even some patients who experience vessel trauma, like aneurysm patients. They might end up putting such a demand on the heart, such a pressure on the heart, high blood pressure puts such a demand on the left ventricle that it can't do its job. And so then it backs fluid up into the lungs. Pulmonary edema means lung fluid. That fluid, typically in the medical patient, comes from a failing heart, a failing left ventricle. So the classic signs of pulmonary edema are trouble breathing, very high blood pressure, so 200 over 110, JVD. Remind me what JVD is. That's correct. Jugular vein distension. It makes sense that you would have jugular vein distension because there isn't supposed to be too much fluid in the chest. The fluid is supposed to go in and get pumped out. If it were backing up in the chest, then that would start to cause the blood returning from the head to back up as well. So it makes sense that too much fluid in the chest is going to push against the fluid returning to the chest from the head. And the result of that is jugular vein distension. You would also hear a specific type of lung sound. What is the specific type of lung sound you would hear if there were fluid on the lungs? Maria, anyone?
Crackling?
Yes, crackles is not an incorrect answer. There's a better way to say it. So crackles has two versions, dry and wet, and we could just say rails and fix both of those problems because rails is more specific. Crackles that are dry, they sound like Rice Krispies, that's like pneumonia. Crackles that are wet sounds like air moving through water, sounds like someone blowing bubbles in chocolate milk in the lung sounds. Well, that's fluid, that's water, that's backed up blood, it's edema. So the lung sounds that you would hear on a pulmonary edema patient would be diffuse, which means all over the place. They would be bilateral, both lungs, and they would be more in the bases of the lungs than they were in the apices of the lungs. We remember that the base of the lungs is listened to by going in the mid-axilla, which is the armpit line, just below the nipple area, and having the patient take a big breath. Why would you expect to hear more rails in the bases than in the apices? The apices being the top, the bases being the bottom. Why would we hear rails more in the bottom? Because of gravity. Gravity. Just that simple. Fluid is going to pull wherever gravity takes it. So these patients complain of not being able to lie flat. Because if you lie flat, the fluid goes everywhere, top and the bottom. If you sit up, the fluid doesn't get to cover all of the alveoli, and so your trouble breathing improves. May not completely resolve. There may still be some trouble breathing, but sitting the patient up will improve their condition because it allows more alveoli to be fluid free. If a pulmonary edema patient lies flat, then all of the alveoli tend to cover with fluid and not be able to do their job. So positional dyspnea, meaning my trouble breathing is directly associated with what position my body is in, is another sign of pulmonary edema. So let's go back over them. Pulmonary edema patients are typically from heart failure. That's why the other name for pulmonary edema is congestive heart failure, CHF. Normally, it's caused by congestive heart failure. It could be caused by drowning. It could be caused by toxins, like being exposed to a poisonous gas. It could be caused by a heart attack, where the left ventricle is dying, so now it can't do its job. These patients tend to present with trouble breathing, pink frothy sputum, where they have this persistent cough, and maybe it's productive and it's pink frothy nasty stuff that they're producing. It's not mucus like a cold, it's pink bubbly stuff. That would be very concerning. Hypertension, high blood pressure, JVD, and rales upon auscultation of the lung sounds. When we listen to the lungs, there are rales in the lung fields, most commonly the bases. That would describe a pulmonary edema patient. Now, a lot of congestive heart failure patients fail both of their ventricles. So you could also see swelling in the legs. And if you've got swelling in the legs, you have to wonder if you have swelling in the lungs. Swelling of the left ventricle causing fluid to back up into the lungs. So edema in the periphery. Periphery means your feet and your arms, your hands, your toes, your fingers. That's all your peripheral. Okay? Swelling in the periphery would make me wonder if not only the right ventricle is failing, but maybe the left one is too. And I would immediately listen to lung sounds. And I would assess whether or not there are rales. Rales is the word we use for the sound that pulmonary edema produces. It sounds like blowing bubbles through fluid, blowing bubbles in chocolate milk. When the patient breathes, you hear bubbling. That is not normal. It is very dangerous. It is likely that your high flow oxygen and your Fowler's position will not be enough for the patient. What additional intervention would you use to treat pulmonary edema? Absolutely. CPAP. Hold on 2 seconds, guys. I got to get this. Thank you so much. Yeah. Okay. So that's pulmonary edema. Everybody back with me? Everybody good? Yes? Hands up. Beautiful. Beautiful, beautiful, beautiful. Okay, beautiful. Thank you. That's good. All right. So that was pulmonary edema, and CPAP is the answer. If your good positioning and your non-rebreather at high flow is not working, then we need to put some pressure behind the oxygen, move that fluid out of the way, and let that oxygen do its job. If the fluid sits on top of the alveoli, the oxygen will just be on top of the fluid and nothing will happen. If we add pressure to that, then we can move the fluid and the oxygen actually gets to do its job. Can anyone tell me what are the settings on CPAP? What are the settings that we will use? We can put the pressure to a number, and there are numbers of pressure that we can use. Does anyone remember what those settings are? No? It was
Is
5.
it 7.5 and 10?
Yes, that's correct. 5, 7.5, and 10. That is correct. Now, there are more numbers, but that's a very general understanding. Everyone in the room is breathing a physiological CPAP right now, also known as PEEP, okay, of peak end expiratory pressure. Everyone's breathing a normal physiological PEEP of 5. When you exhale, you don't close your lungs all the way. If you did, then the alveoli would fall on top of themselves. They would close and they wouldn't work. So everyone who is not having trouble breathing, who is healthy and normal, you're maintaining a physiological PEEP of 5 every day, all day. If you get sick, if you start having significant trouble breathing, you start breathing really fast, which we call tachypnea, tachypnea, fast breathing, then you lose the ability to maintain that natural peak end expiratory pressure, that little bit of pressure that keeps your lungs open at the end of every breath. The faster you breathe, the more tired your breathing gets, the less likely you're able to maintain that natural PEEP, which is also known as CPAP. They are the same principle. So when our patients get sick enough, tired enough, exacerbated enough, now they are really struggling to breathe, you are beyond the capability of just increasing their FiO2. You're beyond the capability of just giving them a whole bunch of oxygen and solving the problem. We now need to replace that natural pressure that keeps the alveoli open and happy so we can add oxygen and CPAP to the case, and the patient will oxygenate better than if you had just been using the oxygen. Any questions about using CPAP in any patient who has fluid on their lungs? I've encouraged you before, and I'm encouraging you again. Go and watch EMS-related CPAP videos on YouTube. In the state of South Carolina, CPAP is a skill that is manned by the EMT. You are capable of deploying CPAP in your own scope. Let's go on to asthma. Asthma is better known as RAD, reactive airway disease. Please forgive my fast spelling. Reactive airway disease. It's called that because the lungs are normally open and happy and clear, and they're moving air in and out, in and out. There are people who, when exposed to reactive stimuli, their lungs try to close. For some people, that's exercise and a lot of exertion. For some people, it's weeds and grass and plants and dander, dust and debris in the environment's atmosphere. For some people, it's strong perfumes and colognes, or even products used in our daily lives like hairspray and makeup and products to wash your clothes. Hold on 2 seconds, guys. I apologize. Hey, Andy.
Alright, so I did some moving stuff around.
Okay, guys, my apologies. Let's get back into it. We'll take a break shortly. We're almost done with the last of these. So, asthma is more commonly known as reactive airway disease for the reasons I mentioned. You would expect to see an asthma attack come on acutely. Yes, the patient can have a couple days that are bad, where they've kind of had to increase the use of their known inhalers. So in their sample, they're going to say they have asthma, most likely, unless we're talking about pediatric patients who might be undiagnosed. They might have a history of asthma already. In their medications, they might say that they already sorry, looking at something. They already have an inhaler and they take medications for asthma. So then that's a clue. You could ask, does this feel like your normal asthma attack? Well, there you go. Asthma does not cause the blood pressure to go away. So, unlike anaphylaxis, where you can have a patient who loses their blood pressure, an asthma patient does not lose their blood pressure. So that's a contrast between those two diagnoses because they can look the same, asthma and anaphylaxis. Anaphylaxis can be an extreme allergic reaction caused by maybe a bee sting. Well, asthma is similar in the fact that it is reactive. It is reacting to stimuli that it doesn't like, and so then the lungs begin to close. So the patient will have dyspnea, trouble breathing. The patient will be acute in onset normally, or they'll be able to tell you a story of their asthma's been acting up, okay? The patient will have an SpO2 on room air that's low, so then oxygen helps it and makes it a little bit better. However, it doesn't fix the problem. What lung sounds would I expect to hear? This is the respiratory chapter, so everyone's lung sounds should be getting listened to. What lung sounds would I hear in an asthma patient? Wheezing. That is correct. I would hear wheezing. The difference between a stridor and a wheezing is that stridor occurs in the upper airway and wheezing occurs in the lower. Period. That's it. So you would treat this by oxygen, appropriate position, which is Fowler's position, and albuterol. Give your albuterol, which the EMT can do on their own accord. You can nebulize albuterol in the little oxygen mask nebulizer, or you can use a meter dose inhaler, an MDI, and give puffs of albuterol to the patient. Either way. Okay? Can anyone remind me if we are using a nebulizer, what liters per minute do we put our oxygen source on? Very good. The answer is 6 liters per minute. 6 liters per minute is that sweet spot where we atomize the medication so that it can be inhaled, but the liters of oxygen is not so high that we're losing medication by splashing it against the plastic of the nebulizer. So the answer is I will run a nebulizer at 6 liters per minute. You squeeze the albuterol into the little cup. You put the top on the cup. You plug the cup into the bottom of a non-rebreather mask. Then you take the oxygen tubing and you run it from the bottom of the nebulizer to the oxygen source. And you turn it up to 6 liters per minute. Any questions? We're going to have quizzes about medications going forward in lab. We're going to have quizzes about acronyms going forward in lab. The results of those quizzes are that if you don't know an answer that you should know, you get to write it 25, 50, 100, 150, 200, 250 times. Please be studying, because if we take one of these quizzes and you fail it, all of the answers that you did not know, you will be writing them repetitively for those amounts of times until I am confident that you have retained the material. Chronic obstructive pulmonary disease. Last one, I think. Let me see what the next slide shows us. Yeah. We'll do the other ones too. Well, let's go ahead and take a break. Let's come back at, we're going to say it's 8:10. Let's come back at 8:20. Okay? 8:20. Yes, Maria.
I have a question.
Mm-hmm.
So this happened to me like 2 days ago because I work in the ED, and so a patient came in, 47-year-old female came in with a panic attack. She had no sign of respiratory distress or anything like that. Her vitals were normal. That she took an AKG. She had no discoloration, pink, dry skin. And then as soon as she walked back, she immediately turned purple and she went into cardiac arrest and was spewing out blood everywhere.
That sounds like pulmonary embolism to me. And I'm speculating because I don't have the whole picture. I wasn't there. I wasn't in front of the patient. I would have to know more. But for the patient to have a dyspnea complaint that suddenly worsens like that, there's two things that pop into my head. Either we missed the severity of the patient's condition and they were more sick than we thought they were,
Mm-hmm.
or they really did look really good and there was this big pulmonary embolism sitting in the vessels that go from the heart to the lungs, and it was just waiting on its chance to lodge in that vessel and cause a complete occlusion. With a pulmonary embolism, the normal complaints are sudden trouble breathing, pleuritic chest pain. The word pleuritic means chest, plural means lung, plural
Mm-hmm.
means the space around the lung. So trouble breathing, and when I take a breath, it has chest pain. So those are the common conditions with pulmonary embolus. And this patient may have normal SpO2 and their lung sounds are clear and equal. But then suddenly they go into cardiac arrest. Boom. And then they start, flowing this blood because this big blood clot, because an embolism is a blood clot, could be an air clot, could be a blood clot. Most likely it's a blood clot.
Mm-hmm.
Is just sitting in that big pulmonary artery, and now it's blocked the entire thing. So all the blood going from the right ventricle to the lungs is stopped immediately, which would mean that you get no blood back into the heart. And so the patient immediately goes into cardiac arrest. They turn very purple. And the classic sign of that is that the patient will be completely purple from the nipple line up.
And that's exactly what it was.
Yeah, so that would concern me for PE. And we'll talk a little bit more about that when we get there. Take your break.
Cool.
All right, everyone. Please raise your hand if you're back. Should be 24 of you. Maybe 23, since one of you is having difficulties with technology. Ron Jackson, Sarah Coker, Mitchell Hinton, Maria, Leslie Williamson. That's better, that's better. Leslie's on listen only, so she might not be able to hit the button. All right, let's move forward. Sarah Coker, Ryan Jackson. Make sure y'all put your hand up when you get here. All right. COPD is basically chronic obstruction of the pulmonary pathways. This is typically caused by a multitude of things, most commonly things like smoking, chronic smoking. And so basically this person constantly has a problem exhaling their carbon dioxide. So basically we call COPD patients air trappers. We call asthma patients air trappers because they can take a new breath in, but they can't get breaths out. And so their CO2 levels are through the roof. They can't get carbon dioxide out. So chronic obstructive pulmonary disease patients, one, they will be diagnosed, most likely. They will be on multiple medications for COPD, most likely. Chronic obstructive pulmonary disease. And the obstruction means in the bronchioles, in the large pathways of the lung fields, they fall on top of themselves. They don't hold themselves open very well, specifically during exhalation. Chronic obstructive pulmonary disease patients live constantly at an SpO2 value that's less than 94% on room air. A lot of them are on oxygen at home. They take oxygen at home because their SpO2 is so low that they need constant oxygen support. So you can't go about a chronic obstructive pulmonary disease patient as a clean slate. You got to ask them what is normal for them. It's not like an asthma patient where when they're not having an asthma attack, then they are as normal as everybody else. COPD patients are never normal. They constantly have bad days, and they constantly have, to some extent, trouble breathing. So you have to dig a little deeper and say, well, how much trouble breathing are you having today compared to a good day? If a good day was 0 and 10 was the worst day you think you've ever had in your COPD history, where would today be? That is how you might be able to judge the severity in OPQRST. You got to remember that they're never at normal SpO2 values. So what is normal for you, sir? What is your good day SpO2? And that should be our goal. If they say on their best days their SpO2 is 91%, then our goal should be 91%, not 94, 95, or even worse, 100. When people have chronic disease, we're not shooting for a healthy person's normal. I want you to remember that. So COPD patients are very tough to deal with. It's very tough to judge how sick they are today in comparison with all of their other fairly sick days. They're not ever doing very well. COPD is a terminal illness, and it typically does result in the end of the life of the patient. The sad thing about that is that it takes a long time, and it's quite a suffering period. And so we know that the most common COPD patient is a chronic smoker. We know that chronic smokers are going to weaken their lung pathways, so much so that they end up with chronic obstruction. And it is not curable. It is not fixable. So, what is normal for them? What can we do to get them to their norm? If they're having wheezing, give them albuterol. If their SpO2 is 88% and they say on a good day it's 91, then let's give them enough oxygen to get them to 91. If anyone's in trouble breathing and they look sick to you, give them a non-rebreather at 15 liters per minute. Never be afraid to give someone high flow if they look sick. If this person looks like they're having a ton of trouble breathing, do not be afraid to give them high flow oxygen. There's a lot of talk out there that giving high flow oxygen to chronic obstructive pulmonary disease patients might be harmful. There is no evidence of that. I'm going to say that again. There is no evidence of that. Everything that has ever been said about chronic obstructive pulmonary disease patients not responding well to high flow oxygen is completely anecdotal. It is completely theory. It is not backed statistically. There are not patients admitted to the emergency room for hyperoxygenation COPD. That has never occurred. We don't have a case. Not a single one. So if anyone ever tells you that you cannot give high flow oxygenation to COPD patients, they are lying. They are wrong. If someone is in distress, breathing distress, give them 100% oxygen at high flow rates. Any questions about that? You and I breathe because we have too little oxygen or too much CO2?
Too much CO2?
I told you that these patients live their lives with too much CO2 for years and years and years on and on. After a while, their body, because of the constant acidosis, remember that CO2 is an acid, the constant acidosis burns their chemoreceptors, and they no longer are able to breathe because of high CO2 levels. They switch to breathing because they need oxygen. That's called hypoxic drive, which makes sense. Hypoxic drive means that you breathe, you are driven to breathe by hypoxia. When your oxygen level drops low enough, it stimulates you to breathe. Most of us are not breathing from hypoxic drive. We breathe from hypercarbia, too much carbon dioxide. The theory is that if someone is hypoxic driven and you gave them a ton of oxygen, they would have so much oxygen that it would never drive them to breathe, and that they would become apneic and they would stop breathing and you would have to breathe for them. There is no proof of this. There is not a single case of this known to modern medicine. This is only anecdotal. It does not exist. It is not real. The book may talk about hypoxic drive. The book may ask you questions to see if you will buy in to hypoxic drive theory. But you now know it's false. COPD patients are indeed hypoxic driven, but they will not become apneic because you are over providing oxygen. It doesn't happen. It's bullshit. Okie dokie? So don't ever let anyone tell you not to give high flow oxygen to chronic obstructive pulmonary disease. Let's move on. The treatment for COPD is oxygen, albuterol, emergent transport. Pertussis is a bacterial-based cough that we are vaccinated against. I'll let you read up on it. It's very contagious, and not a lot of people get it because we are vaccinated against it. If you do get it, they call it the year-long cough. Why? Because it doesn't go away. Pertussis is extremely aggressive. It doesn't necessarily result in a lot of lives lost, but it is a very aggressive bacteria that causes an extreme cough over very long periods of time. We're vaccinated against it. I'll let you read about cystic fibrosis. I will move on to pulmonary embolism. Pulmonary embolism is when air or a blood clot blocks the pathway from the heart to the lungs. The blood flow from the heart to the lungs. As you might well anticipate, that would result in death quite quickly. If you cannot get blood out of the heart and to the lungs, then you cannot get blood back to the lungs. So once again, understanding the blood flow of the heart is really important. The blood flows from the vena cava to the right heart, from the right heart to the lungs, and from the lungs back to the left heart, from the left heart to the body. If you were to block the blood from the right heart going to the lungs would have no blood to put back into the left heart, and you would die immediately. Boom! If you were lucky enough that the embolism wasn't big enough to completely stop the blood flow from the heart to the lungs, then you would complain of sudden onset trouble breathing. But your lung sounds would be clear. Your SpO2 values may even be normal. But the patient is clearly in breathing distress, and they normally complain of sharp chest pain. That clot causes sharp chest pain. These patients are pretty dangerous, and they're pretty deadly. If we had someone with sharp chest pain, sudden onset, trouble breathing, with clear lung sounds and a 98% SpO2 on room air, run! Get them on the stretcher and run emergently to the hospital. Give them high-flow oxygen and emergent transport. There's nothing else you can do. If that clot dislodges enough to move into the vessel in such a way that it completely blocks the blood going from the heart to the lungs, then the patient will immediately arrest and die. I remind you, the symptoms are sudden onset trouble breathing, sudden onset sharp chest pain. Lung sounds are clear. SpO2 is normal. That sounds like a pulmonary embolus to me. Pneumonia. I'm sorry to hear that, Leslie. I'm sorry to hear that. It's a pretty tough condition. By the way, guys, people get pulmonary embolisms because of smoking or some types of hormone therapy replacement. And anytime you combine both of those together, it's a recipe for death. So take an elderly woman who is on hormone replacement therapy because they've gone through menopause and they no longer produce those hormones correctly. And so then we put them on hormone replacement therapy and say they smoke with that therapy. That is a recipe for death. Some people say you are pregnant and you smoke. That is a recipe for pulmonary embolus death. Say you are taking pregnancy prevention, birth control, and you smoke. That is a recipe for pulmonary embolism death. The other causes of pulmonary emboli are prolonged sedentary lifestyle, meaning the patient doesn't move around a lot. So think nursing home patients. Think long-term travel. So I got on a plane and I went to another country and I didn't move at all for hours and hours and hours. That might set up a blood clot. Long surgery procedures and breaking long bones. When you break long bones, they tend to form fat emboli. And those fat emboli can move from where the bone was broken up into the lungs and kill you. Those are the common reasons for pulmonary embolism. Pneumonia. Pneumonia is chronic, gradual onset. So I've been feeling bad for about 2 weeks. I've been feeling a little bit of trouble breathing that gets worse and worse every day. And it's worse at night. I've been having night sweats and I wake up just drenched. And I've been having intermittent fevers. And my lungs hurt. It literally hurts to breathe. It hurts to cough. I'm constantly coughing. I've had these temperatures. I just feel very weak, very lethargic, very sick. That is classic pneumonia. So, temperature. You don't get a high fever in asthma. You don't get a high fever in COPD. You don't get a high fever in CHF or pulmonary edema. You don't get fevers in anaphylaxis. So, fever would be a great indicator to include or exclude a field impression of pneumonia. Pneumonia is very common in elderly people. Pneumonia is very common in people who get sick often. Pneumonia is very common in people who are confined in a small space with a lot of people. Think prisons. Think hospitals. Think nursing homes. Think church communities. That's pneumonia. Pneumonia will have clear lung sounds in most fields, but in little pockets, if you listen all over, you would hear dry rhonchi. You would hear dry crackles, which is basically mucus. When the bacteria in the lungs build up into pneumonia, mucus surrounds the bacteria in an attempt to make you cough the bacteria out. And sometimes that works and sometimes it doesn't. But that mucus is what's making that dry crackle noise. The sounds like you're breathing in Rice Krispies noise. So, trouble breathing, lethargic, night sweats, fevers, gradual onset over the course of days to weeks, that would be common of pneumonia. Okie dokie. I am going to let you read the rest of the slides. I'm going to let you do the rest of the studying, and I'm going to move you on to chapter 17. I am going to give you the most common emergencies. I'm going to give you the ingredients to those emergencies. I'm going to give you the treatments for those emergencies, and you are going to go do the rest of the study work. Let's take a 10-minute break. Come back at 8:45. 8:45. Welcome back, my chipper little EMT students. Can I get a hand raised for those who are still with me? Come on, that number's not high enough. I need more people, so I don't count you absent on the roster. Mind counting you absent. Mitchell Hinton! I believe I had to call your name last time. There we go. Maria Brufy, where are you? Let me boot you. Boom. See what that does. Who else? Sarah Coker. Ah, nick of time, Sarah. I was clicking the remove you button, and here you are, shining like a diamond.
Here. I was here. I don't know why I didn't register that I raised my hand.
It might just be a connection issue, which is still a good way to get you to reconnect. And you may not know it on your end. I may only see it on my end. I did see you immediately log back in, so you're good.
Okay.
No worries. It'll self-correct, and then I'll come back and see it. It's okay, Sarah Coker. I'm sure you were tending to Noah. All right, let's move into cardiovascular emergencies. You better be bringing those cookies to the lab. I know that. All right, cardiovascular emergencies, children. Same thing we did in the respiratory chapter. We go through the most common ones, and we talk about the symptoms, talk about the treatments. You do the work. Clearly, we're back on you must know the anatomy, you must know the physiology, and as we can see from the initial lecture on pulmonology, we're not quite as good as it should be. So every chapter does review the anatomy, and so make sure you spend time on that. Don't skip it, because you need it. You need that review. Okie dokie. Chest pain, cardiac arrest, and the intricacies of chest pain. We'll talk about aortic aneurysm and dissection. We've already talked a little bit about clots, which are basically thromboembolism. Thrombus means when a clot is localized somewhere. So you can have a thrombus in your leg. And embolism is when the clot has moved from its original origin or its etiology to a new place. So a clot can originate in the heart and move to the brain. That's called a stroke. A clot can originate in a broken leg and move to the lungs. That would be called a pulmonary embolism. So thrombus versus emboli, you need to keep up with that. Okay? Thrombus versus an emboli. You need to know what that is. Okay? So a thrombus is stuck somewhere versus an emboli has moved. Make sure you know that. Make sure you know that. A thrombus typically stays still and an emboli moves. We'll talk about heart failure again. We'll talk about hypertensive emergencies, which is a short little bit of a little ditty. Okay? So, let's do that. Let's begin with chest pain. Chest pain patients are also called angina patients. The other word for chest pain is angina. Then you've got heart attack, which presents with chest pain. All of those people are best known as ACS. Acute coronary syndrome. Basically, patients experiencing chest pain in a way that makes us think one of their coronary arteries are blocked. You got to remember that the coronary arteries are the arteries that feed the heart with its own blood supply. It's not magic. The blood that's going through the ventricles, the blood that's going through the atrium, that blood is for the body. That blood's for the brain and the organs and all the rest of you. But what blood feeds the heart? During diastole, the resting phase, the left ventricle squeezes during syncope, okay? So the left ventricle squeezes during, and that is your systolic, right? The top number of your blood pressure. So the left ventricle squeezes in systole, and then there's a relaxation period. During the relaxation period, there's a backflow of blood into the coronary arteries that feed the actual tissues of the heart. If one of these arteries, the right coronary artery, the left anterior descending coronary artery, the circumflex coronary artery, which goes down the back of the heart, if these arteries do not feed blood to the heart tissue, they are blocked by plaque. Then you're having a heart attack. The medical word for heart attack is myocardial infarction. There are different types of heart attacks. There's a non-STEMI, there's a STEMI, there's angina pectoris, there is coronary spasm, ischemia. There's all kinds of things that can happen that would cause the blood back feeding the heart not to make it to all the tissue of the heart. All of those things tend to result in chest pain. And all of those things are considered acute coronary syndrome. Why am I telling you this? Because there's not just one version of chest pain patient. You got to be careful with chest pain patients because there are multiple different types of heart attacks. The most common one is a STEMI. Don't write this down. But STEMI means ST segment elevated myocardial infarction. What that basically means is, remember that big 12 lead we can take on the cardiac monitor? We can take all those leads and we can put them around the heart and it takes a little picture. If the heart attack shows up on that, it's a STEMI. There are other heart attacks that do not show up on an EKG. So just take all that information in. Let's talk about how these patients present. Typically, their chest pain is the complaint. I have chest pain. Maybe they have a little shortness of breathing with the chest pain because those organs are in the same real estate. The heart sits in between and behind the lungs. So when one of those organs are upset, the other one quickly finds out and begins to have its own little bit of trouble. So which came first, the chicken or the egg? You might ask the patient, were you having chest pain first and then trouble breathing, or were you having trouble breathing and then chest pain? Maybe they know, maybe they don't. But chest pain will be the overriding complaint. Typically. This chest pain is commonly qualified. What is the quality of your chest pain? How does your chest pain feel? They will typically say the quality of their chest pain is like a pressure, a dull aching, an elephant sitting on my chest. I just feel like there's a weight on my chest. That's how they will describe this chest pain. It's not uncommon for it to radiate into the left arm and left jaw. These patients will tend to be diaphoretic, which means sweaty. The patients will have some amounts of history of smoking, high blood pressure, coronary artery disease, atherosclerosis, where they are known to have a buildup of plaque in their vessels. Maybe they take blood pressure medications. Maybe they take hyperlipidemia medications where they've been diagnosed with high cholesterol. The high cholesterol is what causes the plaque in their arteries. So if they're a smoker, if they're they take a high cholesterol medication, they take a blood pressure medication, if they say that they've had family members like their mom or their dad that died of a heart attack or had significant heart attacks, those things would all be inclusive, more inclusivity that the patient might be experiencing a heart attack. So remember, chest pain feels dull, achy, elephant sitting on my chest, weight on my chest, pressure on my chest, potentially radiating from the left arm and jaw. They'll describe the pain as underneath their sternum, substernum chest pain. They will commonly be diaphoretic. They respond well to aspirin and nitro. If they rated the severity of their pain as 10 out of 10, and you gave them 324 milligrams of aspirin, they chewed that up, and then you gave them 0.4 milligrams of sublingual nitro, and now their pain is a 6 out of 10, that is more indicative that they're having a heart attack. The fact that those medications, which thin the blood and open up the vessels, would have decreased the pain would be more indicative that the vessel is clogged, it's blocked, it's obstructed. And opening it up helped the problem. Myocardial infarction. Angina pectoris is more associated with a chest pain condition that resolves with nitroglycerin, and those people may or may not be having a heart attack, most commonly not. And they will know they have this condition, angina pectoris, and they will have been given nitroglycerin to take at home. And they will tell you, I took my nitroglycerin and my pain went away and I'm okay now. Or worse, they say, I took the maximum amount of doses, which is typically 3, of my nitroglycerin and I still have chest pain. And my bottle says, if in 3 doses I still have chest pain, call 911. So I called 911. Okay, well, what is your pain right now? It's still a 10 out of 10. That would lead me to believe this patient might no longer be angina pectoris. They might now be myocardial infarction. Chest pain patients get oxygen, emergent transport, if you believe them to be cardiac emergency in nature. They get aspirin and they get nitro, unless contraindicated. Can anyone remind me why you would not give nitroglycerin to a patient? Anyone? Low blood pressure is the most correct answer. There are multiple answers, but low blood pressure is the most aggressive and reasonable answer. Nitroglycerin naturally lowers blood pressure, so then you would not give it to a patient with low blood pressure. Mazara Rocha is also correct that you would never want to give nitroglycerin to a patient who's taking sexual enhancement drugs like Viagra or Cialis, or more importantly, pulmonary hypertension drugs like Viagra and Cialis. Remember that Viagra and Cialis, although they are known to help with impotence, they are most invented for patients who have very high lung pressures that prevent good perfusion. That medication will reduce the pressures in the chest and allow for better perfusion. So women can take Viagra. Babies can take Viagra. It's important that we not give nitroglycerin to anyone who takes Viagra in the last 24 hours. Aneurysm, specifically aortic aneurysm. The aneurysms of aortic nature can run from the top of the aorta to the bottom. I remind you that the aorta begins at the top of the heart in the chest. It goes up towards the collarbone on the left side of you, and it goes all the way down into your abdomen, down into your navel area. That is a huge high pressure pipe running from the top of your chest all the way to your belly. If that high pressure were to become such that it weakened the wall of the vessel, and it made the internal lining of the vessel begin to tear, you would have an aortic aneurysm. I remind you that vessels have multiple internal layers. So an aneurysm means that the layers have begun to break away and there is this bubble on the vessel. But what separates an aneurysm from a dissection is whether or not that bubble has begun to leak. Now, you can leak slowly or you can dissect massively and die immediately. Bam, dead. People do both. Aortic aneurysms dissect and begin to leak, and that gives us a little bit of time. We can take that person to emergency surgery and they can try to fix the dissection and the patient doesn't die. If it were to dissect quickly, the patient would die immediately and there's nothing we could do. So the book has pictures of aortic dissection. I think they're drawings. They're not real ones. But there are pictures of aortic dissection. Here's a good vessel picture. Okay? If there was a bubble on this vessel, that would be a dissection. Let me go to it real quick. See if it's in here. I believe that it is. As you can see, there's a lot of information for you to go through. A lot of that is related to cardiac arrest care, which you already know. Okay, I did not see it in there, but it is in your book. You just remember to go into your book and look at the picture of aortic aneurysm. But again, an aneurysm is when there's a bubble on the side of the vessel because the internal layers have begun to break down. If that bubble breaks down enough that you begin spewing blood out of the aorta, that's called a dissection. It can be a little dissection. It can be a big one when you die immediately. What is the treatment for aortic aneurysm? Recognize it, treat the patient for shock, and emergently transport. There's nothing else you can do. There's no medication that you can give. There's nothing else you can do. You can call for ALS backup. They can do some additional things. But this patient needs a surgeon. That's the cure. They need a surgeon if they make it there. Be gentle with them. Softly get them on the stretcher. Softly drive them to the hospital to the best of your ability. And they need a surgeon. You have to correct it with surgery. What are the symptoms? Acute, burning, sharp, tearing pain in the chest that goes into the shoulder blades, in the shoulder blades that goes into the chest, or even in the abdomen. I just feel like a knife is stabbing me in my abdomen and it's running into the middle of my shoulder blades and it feels like the knife has been set over a fire and it's burning and it's hot and it's tearing and stabbing. That is classic quality of abdominal and chest pain related complaints associated with aneurysms. If they say it's sharp and burning and stabbing and tearing pain, that is not the same way we described the heart attack patient where it was a dull, achy elephant sitting on the chest. No. The aneurysm patient will describe it as sharp and burning and stabbing, and it will go through and through. Starts in the front, goes to the back. Starts in the chest, goes to the shoulder blades. Starts in the abdomen, goes to the shoulder blades. That's common of aortic dissection and aneurysm. They probably have a history of high blood pressure. you will probably find them hypertensive, 200 over 100. The common cause of aortic aneurysm is untreated, non-compliant high blood pressure. The vessels aren't supposed to be under great pressures beyond the 120 over 80 range. Cold toe, cold foot is true. When the tank, which is supposed to be closed, right? Your vessels are a closed tank. Imagine now that you have this bubble on the side of the tank. Depending where that bubble occurs, you might have a difference in blood flow to the right or left side of the body, the arms or the legs, the left side versus the right side. So yes, it is true, Sierra, that aneurysms cause a differing of blood pressure from left to right. It causes a differing of perfusion from one foot to another foot. So there are changes in sensation, temperature, feeling, numbness and tingling from extremity to another. If someone were to tell you that over the course of a couple of weeks they've been having a burning, tearing pain in their chest and that their feet just get cold, and one side of me doesn't really get cold and the other one does, and you feel their legs and there is a very different temperature from one side to the other, either that person has an aneurysm or they have a blood clot in that leg. One or the other. So yes, that's true, Sierra. And it makes sense because aneurysms create additional tank. So then the tank would begin to misbehave. You're not supposed to have this bubble on the side of a great vessel that is now circulating blood volume through it. So then that would change the blood pressure from right to left. It would change perfusion from right to left. We call that pulsus paradoxus, meaning this bubble on the tank is causing the pulsatile blood flow from one side of the body to be different than that of the other. Interesting stuff, huh? We already talked about blood clot. Heart failure, we already talked about. If the right heart fails, then the extremities would swell. If the left heart fails, the lungs would fill up with fluid. You need to know that. You won't do well on the test if you don't know that. High blood pressure emergencies are when someone gets chest pain, altered mental status, shortness of breath from the actual blood pressure being that high. It's pretty rare. It's pretty rare to have a hypertensive emergency because people who have very high blood pressures have had those high blood pressures for some time, over periods of time. So typically the treatment's going to be that you find them 250 over 110. Hey, holy crap, your blood pressure is really high. We need to transport you to the hospital. Maybe they have some amount of symptoms or other complaints, but you also may just find this with no complaint. Never let a person willy-nilly refuse without you telling them it's a bad idea if their blood pressure is over 180 systolic, over 100 diastolic. That's very dangerous. Is it common? Sadly, unfortunately, yes, it's too common. But we want to have informed the patient, hey, that's a dangerous blood pressure. Is that normally your blood pressure? Well, yeah, that's my blood pressure every day. Okay, well then you need to go to your primary care doctor and let them know because this is not going to work. You are going to have a stroke, or you are going to have a heart attack, or you are going to get an aneurysm. You're going to die. You cannot maintain blood pressures 180 over 100 every day. And some people walk around with 250 over 100. Some people have a diastolic of 140, which means their poor little heart's not getting any blood on the backside. So these blood pressures are very dangerous. This goes on to tell you that heart disease is still a huge problem in our country. This goes on to tell you the anatomy and physiology that we spoke about. I do want to remind you that the heart is both mechanical and electrical, and either one of those sides of the fence could result in an emergency. What would happen to you if you went into a really, really, really bad arrhythmia? What would happen to you if the rhythm of your heart's electrical system just stopped working? What would happen? Come on, answer the question. What would happen if your heart's electrical system just failed acutely? You would go into cardiac arrest immediately. In the American Heart Association class for CPR, we said anyone over the age of 18 who suddenly dies probably had an arrhythmia. And if they didn't have an arrhythmia, they had a heart attack. If the electrical system of your heart just decides to go nuts, you will likely collapse and die right there. There are some rhythms that are really bad that you can stay alive with, but there are most rhythms that are really bad that you will die. How do we know which is which? Well, you'd have to go to paramedic school for that. You'd have to be next level for that. But you should at a minimum know that the rhythm is supposed to go from the top of the heart to the middle of the heart from the middle of the heart to the bottom of the heart. And if that's not true, you're in bad shape. Top of the heart to the middle of the heart, from the middle of the heart to the bottom of the heart. It's a systemic, organized conduction of electrical activity from the top to the middle, from the middle to the bottom. And if someone doesn't follow the rules in there, you die. What would be the treatment for someone who suddenly collapses in cardiac arrest from an arrhythmia? What would be the treatment? AED. Very good. The AED is going to read the rhythm, detect if it's a lethal rhythm, and if it is a lethal rhythm, it's going to shock it. And if you shock it, there's a chance with good CPR, and if we have been very quick on this emergency and it hasn't been going on for too long, then there's a chance we might be able to get back to normal circulation. I'll let you read through that anatomy physiology stuff again. Goes over a ton of stuff you already knew. Radial pulses versus carotid pulses. We talked about angina and AMI, acute myocardial infarction. We talked about heart failure, high blood pressure emergencies, aneurysms. You know how to manage cardiac arrest patients. You know the aspirin dose and the nitro dose, when to give it, who to give it to, who not to give it to. I'll let you read through implanted pacemakers. You know how to use AEDs. You know how to perform CPR. All right. Let's take a 5-minute break and come back and do neuro. 5-minute break and we'll come back and do neuro. 9:20. All right, let's finish up and get out of here. Thank you. Just letting the file load for Neuro. One hand raise at a time. All right. Neurological emergencies, obviously, is talking about the brain. We are going to talk about decreased level of consciousness, responsiveness, orientation, seizures, stroke, status seizures. Anytime you see status on the front of a condition, it means that it's prolonged. It means that it is not stopping. It means it's most deadly. So you can have status asthmaticus. That means asthma that's not responding to treatment. You can have status epilepticus, also means seizures not responsive to treatment, or seizures that keep going. We'll talk about headache a little bit. Let's make sure I'm not missing any of the big ones. Okay. All right, here we go. So, anytime someone has an altered mental status, or in this case, we'll call it a decreased LOC, level of consciousness, level of responsiveness, their decreased orientation, that patient should have a blood sugar check, an oxygen check, and a trauma check, because decreased level of consciousness and responsiveness and altered mental status is constantly about not having enough sugar, not having enough oxygen, not having enough hydration to perfuse the brain. So when you think about the most common reasons for altered mental status, you should think hypoxia, hypoglycemia, hypovolemia. Those things are what cause decreased responsiveness, decreased consciousness. How do you treat it? Treat the patient for shock to whatever necessity you find. Emergently transport and get a complete and thorough assessment to see if there's any reversible cause that you might be able to fix as to the reasoning for their altered mental status. Don't forget about poisonings. Don't forget about toxins. Have they been exposed to something? Is their sugar low? Is their SpO2 low? Those are the simple things we would check. Most commonly, those things would be off and we could fix it. Seizure. The book is going to talk about different types of seizures. The big one that I want to talk about is epileptic seizures or tonic-clonic seizures. Tonic means toned. Clonic means jerking. So they get really stiff and then they jerk and stiff and then they jerk and stiff and then they jerk. Basically, the tonic-clonic is the medical version of flopping like a fish. These are also called grand mal seizures. If you're in the South, they call them grandma seizures. Bless their hearts. Grandma, or even grand mal seizures, are tonic-clonic seizures, are epileptic seizures. They're head-to-toe seizures. They are the idea you think of when you think of seizures. But seizures are very complex. Seizures can be very small, something called petite mal. Maybe only their face jerks. Maybe only their lips jerk. Maybe only their left arm and left face jerks. Seizures can be very complex. What seizures will always have is a change in responsiveness, a change in consciousness. This is not a person who can follow your commands. This is not something you can stop. You cannot talk during it. You cannot stop doing it. That would be constant of a seizure. Seizure patients are an airway concern. You do not die from seizures. You have a seizure and lose your airway, and then die from having lost your airway. If you can clear their airway, open their airway, oxygenate and ventilate their airway, they will not die. Even if they were in status epilepticus, where the seizures are not stopping. They are just continuing on and on and on and on. Or they are back to back, back to back, back to back. They have very brief periods where they're not seizing, and then they're seizing again. Seizures are very dangerous. Not because seizures kill people, but because you lose your airway and you die. If you want to save the life of a seizure patient, keep them in a space that is safe. Clear their airway with suctioning. If the mouth will open, suction with a rigid catheter. If the mouth will not open and they are currently seizing, suction with a soft tip nasopharyngeal suction. Then put in an NPA if the mouth is locked. Then put on a non-rebreather. If you feel like they are not breathing, clear the airway with rigid catheter suction if possible. If not, with nasopharyngeal suction. Put in 2 NPAs and ventilate the patient. How do I know they're not breathing? Because when they stop seizing, their SpO2 is 60. Seizures are not just happening in the brain. They're happening all over. That also includes the airway. The vocal cords are spasming. The airway itself is spasming. You cannot breathe like that. Seizures are an airway emergency. Take care of airway, and you will take care of the patient. It's likely that you will not be able to suction the mouth. You will need to suction the nose. After someone has a seizure, it's really important to check their oxygen because seizures use up a lot of oxygen. It's really important to check their sugar because seizures use up a lot of sugar. They may need their oxygen replaced. They may need their sugar replaced. When you seize, you burn through a lot of your nutrients. If someone is seizing and you cannot ventilate them, do you just wait the seizure out? No, they would die. You need ALS backup. If someone will not stop seizing, we are going to RSI them. We are going to give them a medication that will paralyze their entire body so that they cannot seize. And then we will put in a breathing tube and we will breathe for the patient. And then we will give them medications through their veins that will stop the seizure that's happening inside their brain. When you RSI someone, you don't stop their seizure. It's still happening. It just isn't happening in the muscles because we paralyzed them. But the brain is still seizing. The brain is what started this thing. The rest of the body is just responding to the brain. So, Dylan, if someone doesn't stop seizing, if they become status asthmaticus, in this case it's status epilepticus. If someone is status epilepticus, they won't stop seizing. We need to paralyze them and sedate them, and we need to put in a breathing tube because otherwise they will die. Okie dokie. Let's move on to stroke. There are two types of strokes. They're all called CVAs, cerebrovascular accidents, which is kind of funny, right? Anyone else find the humor in that? Oops, your brain had an accident. A little funny. The two types of strokes are ischemic and hemorrhagic, occlusive and bleeding. Ischemic or occlusive is the same thing as a heart attack, except it didn't happen in the heart, it happened in the brain. In an ischemic stroke, one of the great vessels in your brain supplying blood to a part of that brain becomes blocked, and it results in tissue dying, just like it did in the heart. You had a heart attack. This is a brain attack. In a stroke patient, you have ischemic strokes. There's a clot. You have hemorrhagic strokes. They're bleeding on their brain. Both of these patients will have acute symptoms. The hemorrhagic one can become chronic because bleeding can be slow. So let's focus on ischemic first. Ischemic stroke is probably the one most people think about. It's probably the one you have the most experience with, if you have any at all. Ischemic stroke is the classic, your face goes numb, your face starts drooping, and then your left arm and leg are weak, and maybe they don't work right. Maybe they even don't work at all. So one side of your body starts having trouble functioning. That would be a classic stroke. In the hemorrhagic stroke, the patient actually starts bleeding inside of the brain. Obviously, the skull is a very small space, and there's only so much bleeding that you can do. So when you bleed into your brain, you raise the intracranial pressure, and so then the patient's brain begins to die. They begin to lose bodily function. If you're having a stroke, you can't see clearly. You can't speak clearly. You can't walk and talk clearly. You can't use the left arm and left leg correctly. You can't use the right arm and right leg correctly. Motor function is affected. Speech is affected. Facial symmetry is affected. So, if someone has a stroke, number one thing I need to know is last known well time. When were you last normal? Good night, sweetheart. Love you. Good night. Oh, tell your brother I said love him too. Good night. When was your last known normal? Let's do an assessment on last known normal. Why? If there's a clot in this patient's brain, there's a medication we can give, and that medication will break the clot up. And then the patient will not be having a stroke anymore. Now, I'm giving you the best picture. There's a lot of conversation to be had in what I just said, but I'm just giving you the foundation here. If someone has a blood clot in their brain, there's a medication that we can give that will bust up that blood clot and make it go away. And then the stroke goes away. So they regain function of whatever side of the body they were losing. That medication can't be given to most patients whose symptoms are greater than 4 hours. What I just told you is very important. Not every hospital is a stroke center. Not every hospital has that medication. Not every hospital, even if they have that medication, can give that medication. It must be given under the authority and the direction and the review and the care of a neurologist. Not every hospital has neurologists. Those are special hospitals. If you don't find the patient in this condition within 4 hours, they don't qualify for that medication. So it is important that we know the last known well time. This medication could kill a patient if it was given to the wrong patient. So we need to know when these symptoms happened so that we know whether they do or don't qualify for this medication. In the heart attack patient who had a clot, we can go in there and get the clot out manually and put in a stent, and then the heart's fine. And I'm again talking macro and not micro. We can do the same thing for the brain. This is called percutaneous intervention. This is cath lab intervention. We're going to go into the brain, find the clot, suck it out, and voila, the stroke is gone. Those are the two ways that we can treat ischemic stroke. Ischemia means lack of oxygen due to a clot. So we have a clot, and so there's two ways to deal with it. Either we bust it up with a medication. That's a pretty dangerous medication. Has to be given within 4 hours of symptoms. Or we go to a hospital that is so capable, something we call interventional neurology, thrombectomy capable neurology. Thrombus, remember what that was? Thrombus was a clot, and bectomy means to remove it, to remove the thrombus from the brain. Those are the two ways to deal with a stroke. Not everywhere's a stroke center. You got to go to a stroke center. So big things to think about. Is the patient having a stroke or not? When was the patient last known normal? Are we within 4 hours of their condition beginning? Depending on the answers to those questions is where you're going to take the patient. Hemorrhagic stroke, on the other hand, can be caused from medical reasons and trauma reasons. The trauma one is easy, so I'm going to leave that alone. We'll just talk about the medical patient. In the medical patient, it's likely that they're on blood thinners, and the blood thinner made the blood so easily bleedable that this small little vessel ruptured, and now they have bled into the brain space. It can be venous, it can be arterial. That's the overview of the talk. To assess if a patient is having, this is a little aneurysm, so this would be a hemorrhagic stroke. These are all the vessels going to the brain that could become clotted. So if there was a clot in there, that would be a ischemic stroke, an occlusive stroke. Who had a question? Would someone experiencing a stroke also turn yellowish or cyanotic in addition? I witnessed someone having a stroke and they turned this color. Well, yeah, because the brain controls breathing. And if enough of the brain gets injured, you'll stop breathing and you'll lose the ability to control your airway. A lot of stroke patients get intubated. They get intubated because the clot in their brain or the bleeding in their brain has reduced their ability to maintain airway and breathing. So yes, they can, 100%. So, how do we assess a stroke? Well, we assess a stroke by performing a couple of different options. This that you're seeing on the screen right now are the symptoms of stroke, which can be detected with a stroke assessment like the Cincinnati stroke exam. So, go look up the Cincinnati stroke scale. Most importantly, you're going to look up the Resp stroke scale. Okay? We'll look at this a little bit in lab this week. But in the state of South Carolina, we are required by law to conduct a race assessment on anyone we believe to be experiencing a stroke. And I'm going to do that with you in lab this week. We're going to look at that in lab this week. So we'll basically do a stroke assessment where we test the left side of the body against the right and see if there's any deficits. You're supposed to be able to move your arms and legs. You're supposed to be able to smile with equal facial symmetry. You're supposed to be able to speak in full sentences. More importantly, you're supposed to be able to recognize speech and repeat speech and to understand speech. So in lab this week, we'll dabble into the race stroke scale, and you'll be able to say whether someone is or isn't probably having a stroke. I'll let you read more into that. Remember that everything that looks like a stroke is not a stroke. Low blood sugar is classic looking like a stroke, but isn't a stroke. Don't ever, 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 ever call a stroke. When I say call a stroke, guys, we have code blanks on things. Example, a heart attack is called a code STEMI. You know, that heart attack that I told you shows up on an EKG. If you believe the patient's having a heart attack, you can call a code STEMI. If you believe in the patient is having a stroke, you can call a code Neuro. If you believe the patient's having this big, gross infection in their body, which we'll look at later, you can call a code Sepsis. If the patient is a really bad, sick trauma patient, you can call a trauma alert. These are all verbiages that we use over the radio to say to the hospital, hey, this is something bad and it's a stroke. Get your neurologist on the phone. Get your people downstairs. Let's be ready to receive the patient. So, in a code neuro, you don't ever want to call a code neuro unless you've made sure it's nothing else. Check the SpO2. Check the sugar. Because those things mimic stroke. So make sure it's not something that you think it's not. You look at the patient, they look very strokish, and then it turns out it was just a low blood sugar, and when you corrected the sugar, they get better. Postictal is the period of confusion and disorientation that people experience after a seizure. In seizure patients, typically they will be incontinent, they will pee on themselves, and they will be postictal, which means they can't remember their name, they're very confused, they're very lethargic, they don't know what happened to them, it takes them a good bit of time to come around. That is considered postictal. The period of confusion, disorientation, and lethargy that occurs after a systemic seizure, a systemic seizure, where they had tonic, clonic seizure activity, the flopping like a fish. They tend to be incontinent, they tend to be very confused, and they can look like a stroke patient, but they're not. The next important thing you need to take down is the difference between subdural and epidural bleeding. Both of these are hemorrhagic strokes. So if you're taking notes, put them in your hemorrhagic stroke section. Subdural bleeding is literally bleeding that occurs under the subdural matta. The meninges have layers, and those layers have names, and the dura mater is a layer of meninge. If the bleeding occurs under the dura, it's called subdural. This bleeding tends to be venous, and venous bleeding is slow. So then this patient would become symptomatic over a longer period of time. It is common in elderly people who take blood thinners It's commonly found in elderly people who have fallen down and hit their head. This bleeding will begin to occur underneath the dura mater. It is venous in nature. It is slow, and so it bleeds and bleeds and bleeds. And at first, the patient may have no symptoms. And then over the course of a few hours, they get tired and sleepy and a headache. And, oh, my head hurts. Oh, my vision is blurry. Oh, I can't really walk very good. I'm dizzy. And then eventually, if that's not found and corrected, they become unconscious and they can't breathe on their own and they can't maintain their airway. They may vomit and aspirate. Subdural is a hemorrhagic stroke type. It's common in elderly patients who have hit their head. It's common in elderly patients who take blood thinners. And it is a slow progression of worsening. Make sure you know that. Epidural bleeding is not very common. It occurs mostly in trauma. Epidural bleeding occurs and the patient loses consciousness. It's typically arterial in nature, and you get struck in the side of your head and you go unconscious. Bam, you're out. But then you wake right back up and you have a period of what we call lucidness. Lucid means that you have all your wits about you. You're fully alert, conscious, and oriented to person, place, time, and event. And you're like, whoa, I hit my head. It hurt. And you think you're okay because although you did lose consciousness, now you're fine and you feel fine. And you go home and you go to bed and you never wake up again. Epidural bleeding is most commonly arterial. The most common deadly offender is the middle meningeal artery, which is the artery that runs right down your temple. So think of the side of your head between your eye and your ear. There's an artery that runs through your temple. That's called the middle meningeal artery. The temporal artery is responsible for epidural bleeding. Again, most common in young people, most common in trauma, where you've been a direct hit to the side of the temporal region. Loss of consciousness immediately, but wakes right up feeling fine. They go home, they go to bed, they never wake up again. If you ever remember your grandmother saying, oh, you hit your head, you can't go to sleep. We got to watch you. We got to watch you. And if in a couple of hours you're okay, we'll let you go to sleep. This is what they were talking about. They didn't know it, but this is what they were talking about. It's very rare, but it's very deadly. Subdural bleeds, subdural hemorrhagic stroke is extremely common. Well, I shouldn't say extremely. We see it a lot. You don't see epidural bleeding very often. Subdural is venous, epidural is arterial. Subdural is chronic over time progression, slow progression, I should say. Slow progression. Epidural, bam, unconscious, but then wakes up feeling just fine. Goes home, goes to sleep, dies in their sleep. Both of these are deadly. One is slow, one is fast. One is venous, one is arterial. One is common in old people, one is common in young people. Know the difference. I'm not familiar with that case, Cynthia, so I don't know. There is another version of this called AVM, arteriovenous malformation, and I don't know if that applied to the Liam Neeson's wife case. I'd have to look at that. I'd have to look it up. I'm not sure. Could be. Now, again, aneurysms can cause subdural bleeding. Aneurysms can cause epidural bleeding. Trauma can cause both of these. Blood thinners can cause both of these. Know the difference between the two. Know the difference between an ischemic stroke and a hemorrhagic stroke. Let's talk about TIA. TIA is trans ischemic attack. Let me get to it again. I saw it on the slide. I know it's right here. Ah, there you go. TIA is a stroke that goes away within 24 hours. Let me give it to you more realistically. You go to a patient's house and you go inside and you're like, oh my God, they're having a stroke. You get them in the truck, you run emergency to the hospital, and halfway to the hospital, whoop, the stroke is gone. That's called a TIA. Transient ischemic attack. Transient means that it came and it went. It isn't to be confused with a fake stroke. There's no such thing. It isn't to be confused with a non-emergency. It isn't to be confused as being non-mattering. A TIA is equivalent to a chest pain event that wasn't a heart attack. It does not mean that there's no problem. If you have chest pain, something's wrong. It may just not be a heart attack today, but it'll probably progress to one. The same is true for TIAs. Your TIA may not become a full-blown stroke today, but it might progress to one. TIAs are typically considered precursors to a stroke. About a third of patients who have a TIA will experience a full-blown stroke. A third of those people, like 33% of all people who have a TIA, will actually then have a stroke. So, TIAs still need to go to the hospital. If you're on scene with a stroke patient and all of a sudden it resolves, don't say, okay, you're good now. They need to go to the hospital. Okie dokie? I'll let you read that. If you don't read these chapters, you're screwed. I'm telling you. You don't read these chapters, you're done for. There is no way to move on if you don't read these chapters. I already talked about the importance of those. We already talked about the postictal phase, which is the period of confusion after a seizure. Syncope. Syncope is fainting. Syncope equals fainting. How do you know if someone had a seizure or syncope? That's the classic question. Grandma's in church and she's just doing her thing. She's worshiping and the spirit got going and whoop, she was speaking in tongues. She was having a great time. And then whoop, out on the floor. She's out. At first, everyone just thought she had gotten the spirit. And so they were just happy as they could be for Grandma, clapping and praying over her. Well, she's not coming around. So they're not so sure she's in church with the spirit anymore. However, once she hits the ground, her blood pressure resets, and she wakes up and she's like, whoa, I fainted. The difference between a seizure patient and a syncope patient is that in seizure patients, they wake up very confused. In seizure patients, they pee on themselves. Syncope is when the blood pressure couldn't respond fast enough to the patient's conditions, and so then they pass out. However, once they pass out, they're in supine position, and the blood pressure stabilizes, and they wake right back up again. And they are their normal mentation. They are not confused. They did not pee on themselves. And normally, they get rehydrated and take a break, and they're good to go. That's the difference between seizure and syncope. Here's the problem with syncope. The most common reason for someone to pass out is vasovagal syncope, secondary to dehydration. Vasovagal. What that basically means is every time you change position, your body squeezes the tank. If your body were to not squeeze the tank fast enough for the change in your position, you would just pass out. Bam! just like that. Take a person who has no volume. They've been working in the yard all day. It's very hot. They've been sweating and they haven't been hydrating. So they go to stand up. They've been bending over their garden. They've been gardening for an hour and then suddenly they stand up. But they don't have any volume. So then they fall right out. Pow! If you rehydrate that person and you get them back to a good hydration status and you cool them down and you put them back to normal, not POTS, Maria, that's a whole different thing, then they will be fine. And they move right on. Here's the problem. Although vasovagal syncope due to dehydration is the most common cause for syncope, syncope also occurs in all the deadly things. Arrhythmia can cause syncope. Heart attack can cause syncope. Severe emergent blood pressure changes can cause syncope. Incorrect dosages of chronic medications cause syncope. All the things that can kill you cause syncope. How do you know whether you have one or the other? You don't. So then we should encourage syncope patients to go to the hospital and have all the tests run to make sure that it's nothing else. After we run all these tests, if none of those things come back bad, then we chop it up to dehydration-related syncope. That's how that works. But you won't know if it's the bad version until you run all of those tests. So there's the difference between a seizure and a syncope. And there's the problem with syncope. Okie dokie. Make sure you read through that. Remember, check the sugar. Check the oxygen level. Have they been exposed to any drugs? Have they been exposed to any trauma? All of those things cause AMS. AMS is altered mental status. Why do some people faint in the sight of blood? So that's called psychogenic somatic syncope. There's a lot of things that's called, but generally speaking, people get queasy when they look at blood, and for whatever reason, the body resets itself. So basically, they're just queasy. And so a mentally perceived issue is transitioned onto the body. That's called psychosomatic. Why does it happen? There's a ton of different beliefs. But what we do know is that the brain can be so strongly in charge of a response that it causes really funny things to happen in the body. What doesn't happen, Cameron, is they don't die. They don't go into an arrhythmia. They don't lose their blood pressure and die. As soon as they faint, everything returns to normal. It's very scary. They can even kind of look like they're seizing. So it doesn't mean that it's not a very alarming thing to occur. We know it's psychogenic somatic, when they return to normal and they're not dead. If someone saw blood and they fainted, but then they don't get back up immediately, then you would need to worry because something else is going on. Why that happens, we don't really know. How it happens, we know more about. It is from the ability of the brain to control the somatic response. Somatic means body, so tank, heart, blood pressure, heart rate, breathing rate, consciousness. The brain is extremely powerful, really powerful, and super, super amazing in ways that we will never, ever, ever understand. It is so powerful, in fact, that if you scare the brain faster than it can respond, the typical result is syncope. That's called psychogenic somatic syncope, which is pretty cool, I think. It could also result in death, but it doesn't happen a lot. It's very rare. And super funny, I think. If you scared the hell out of somebody coming around the corner and they just died. That's hilarious. Not really. Learn Glasgow Coma Scale. Here it is again. Learn it, learn it, learn it. We'll review it again in lab. We will definitely go over race score to determine how likely the patient is to be having a stroke. Here is the Los Angeles pre-hospital stroke screen. There are tons of them. Cincinnati, Los Angeles, race, MIH, NIH, the men's assessment. There are tons of them. We'll look at race score. Why? Because the state of South Carolina has adopted race score as its dominant method for detecting a stroke. I'll let you look at GCS. We're going to learn GCS again. You will get a couple questions on migraines, so take a look at that as to how migraines present, why they are very difficult to diagnose. They can really look strokish. They can really look seizure-ish. So migraines are no joke. They can really have a systemic effect on a patient's condition. So look at the migraine talk in the book. You can differentiate that typically from strokes and seizures because they want the lights turned off. If everything is quiet and calm, then they feel better. They can get nauseous. So if you give them anti-nausea medications, they feel better. There are migraine medications, so maybe they already have a diagnosis and maybe they take migraine medication. Migraines are no joke. They're very difficult to control, very difficult to treat, very difficult to diagnose because they look like other more severe neurological conditions. So take a look at that. I've used up all my time. Huge chapters. You are not going to make it through this class if you don't read the medical chapters. Please read these chapters and listen to them on the audiobooks. If you don't like reading it, if that's not your thing, then listen to it on the audio. Okie dokie. Any questions for me? Good night, everybody.